Naruvi Hospitals, promoted by the Sanko Foundation, is the brainchild of the founder-chairman Dr. G.V. Sampath. Belonging to Vellore, the medical hub of India, Dr. Sampath's vision to create a medical destination for the people of Vellore in particular and others from India at large and also overseas resulted in the establishment of a hospital here, a real crown jewel in the field of healthcare. Large numbers of people belonging to Vellore and the surrounding districts have been known to travel to Chennai and Bengaluru, both nearly 200 kilometers away from Vellore, seeking medical care due to the dearth of facilities and the hardships faced by the locals to access available services. As per the vision of the chairman, the best in healthcare, both in terms of medical and nursing professionals as well as sophistication, were infused into the institution, making sure that patient affordability was addressed at all times. Less than a month after Naruvi Hospitals opened its doors to the public, the second wave of COVID loomed large as life. We took on the challenge and quickly rose to the occasion, catering to the local population and some from outstation as well, adding close to 40 critical care beds and over 200 ward beds to the COVID care pool. Much as it was hard for a 1-month-old hospital to handle such large volumes of very sick patients, Naruvi Hospitals was able to contribute significantly in our country's efforts to save people from the disastrous end that COVID was driving people to. Naruvi Hospitals is positioned as a high-end tertiary care center. Our focus on ethics, transparency, patient satisfaction, and an academic outlook in everything we do ensures that doctors, nurses, and others in the care team are performing at their conscientious best to not only treat patients' ailments but also to make them happy overall when they leave our hospital. We have tied up with the Henry Ford Health System, HFHS, based out of Michigan State in the United States of America. HFHS is one of the old and leading healthcare delivery systems in Midwestern America. The main aim of this tie-up is to have constant transfer of knowledge and to get access to the time-tested practices they have been following for decades, which ultimately translated to patient care. Naruvi Hospitals is a completely paperless and filmless hospital. The Naruvi philosophy of care is embodied by our motto, Fragrance of Care. The doctors in Naruvi are largely trained in the best of medical institutes in India and come with years of rich experience in their fields of expertise. With the philosophy and its pallbearers, the medical and nursing professionals, the high-end equipment, and the building infrastructure complete the holistic picture of Fragrance of Care. The hospital is 475 bedded with a 25% critical care bed count. Naruvi Hospitals boasts of an over 5 lakh square foot building spanning 14 levels. The building is completely air-conditioned, conforming to ASHRAE standards with zone-specific air conditioning to reduce cross-infection between different care areas. Our laundry is 100% barrier washed. We have a top-of-the-line sterilization department with machines with 95% water-saving machines, saving up to 300 liters of water every running hour. We have all the major medical and surgical specialties. There are 16 modular operation theaters with laminar airflow. All the equipment in the ICUs and OTs are pendant mount to avoid clutter on the floor. All the departments are equipped to the most modern standards with the best and latest equipment so as to be able to provide the best end-to-end treatment to our patients. State-of-the-art cardiac cath labs, the latest robotic hybrid OT, ECMO, interventional pulmonology, high-end orthopedics, general and bariatric surgery, epilepsy monitoring unit with robot-guided epilepsy surgery, neuro monitoring, navigation, the latest lithotripter, urology laser are just some of the arrows in our quiver. Our primary focus, though being the local Vellore people and Indians at large, we are working towards attracting overseas patients as well. We have started an office in North Sudan in Khartoum. We're in the process of tying up with the governments of Oman and Seychelles as well. In all, Naruvi Hospitals is more than a hospital. It is an experience.
everyone.
I couldn't share my video.
Ma'am, we can start.
Good morning, everyone. I welcome all of you to the session. We have today within the webinar Dr. Nagarajan has joined us.
No, ma'am. My video, I couldn't share my video. Host has blocked it. Somebody has to open the video. Yes.
Good morning, everyone.
Good morning.
This Hindu Wellness webinar is about adolescent suicide, busting the myths. We have with us three eminent panelists, Dr. Shainika R., Dr. Ravindra Kant Tangela, and Dr. V. Nagarajan. Welcome to you all. Dr. Shainika is the team lead for the Department of Psychiatry and Child Development Unit at Naruvi Hospitals in Vellore. She completed her MD in Psychiatry from the Institute of Psychiatry, Madurai Medical College in 2017. Then she pursued her fellowship in Child and Adolescent Psychiatry from the Christian Medical College, Vellore. Areas of interest are neurodevelopmental disorders, including early interventions in autism, school mental health, and consultation liaison psychiatry. She will speak on how and why adolescent suicides occur. Welcome, ma'am.
Thank you.
Dr. Ravikant Kapela, Director and Consultant Child and Adolescent Psychiatrist, Dr. Ravi Guidance Clinics and Little Wings Child Development Center, Hyderabad. He has pursued his DM in Child and Adolescent Psychiatry from PGIMER, Chandigarh. He has been working exclusively with children and adolescents since past 6 years in various organizations. He will speak on treatment of adolescent depression. Welcome, sir. Dr. V. Nagarajan, Senior Pediatrician of Naruvi Hospital, completed his MD in Pediatrics in Chegalpet Medical College in 2013 and worked as Assistant Professor in Medical College for 4 years. He is currently working as pediatric consultant at the Naruvi Hospital. Nagarajan will launch the session and will speak on how to recognize early signs of adolescent suicide. We picked up this theme because today is World Suicide Prevention Day, and it's a timely session that we are having, given that a lot of children are undergoing stress thanks to results from either national eligibility test or the recent EUET, and now the engineering admissions that are happening. I welcome you, doctors, to please start the session.
Can everybody see the
Yes, sir.
PPT?
Yeah.
So I will be talking regarding recognizing the early sign of mental illness in an adolescent. So suicide in an adolescent is a tragedy by itself. It has a rippling effect. It's a tragedy to the family. It's a tragedy to the parents. So it's a tragedy to the society as a whole. So by recognizing the early signs, we as a parents and we as a family and neighbors, society at large, we can try to reduce the suicide. And so let me discuss let me see regarding how to recognize these early signs. So as you can see in the middle of the picture, that's an adolescent penguin, what you're seeing here. So the adolescent is a transitional period where the age group, it has not left the childhood period yet, and it has not become an adult yet. So it's a transitional period undergoing tremendous physical changes as well as mental changes. It's an emotionally vulnerable period where the mental illness is very, very common. So it's an age group between 10 to 19 years of a childhood period. As I told you already, it undergoes rapid physical, mental, and emotional development. They still need our help as an adult because it's an emotionally vulnerable period. So how big is the problem of suicide in an adolescent? It's very, very alarming. In India, in every year, some 11,000 suicide deaths in adolescent age group occurs. That accounts to 31 children every day. That is very alarming. What about the suicide attempts? It is even more common. For every suicide deaths, there are more number of suicide attempts that accounts to nearly every attempts every 90 minutes. So what about the mental health issues which underpins the suicidal tendency? It is actually very, very common. So according to World Health Organization, 1 in 7 children of 10 to 19-year-old experience a mental health disorder. That is actually very common, which is largely unrecognized and untreated. We as a family usually tend to just neglect as some cranky adolescent, and we never seek mental health care. So the mental health issues and the suicidal behavioral tendency is very, very large, and it is very unrecognized health disorder. As you can see in the pie chart, family problems and illness contribute a significant proportion of suicidal tendency, and there's a 1% chance of suicidal tendency with failure in examination in adolescent age group. So it is because such mental illness is very common. It is very important to recognize mental health problem in adolescent early. All these signs which I am going to tell you are actually normal response to stress. But if these signs are very persistent, if it is troublesome in day-to-day activities, and which could not be managed by the parents at their home, it is time to seek a professional psychiatrist help. So any child with a mental health disorder, say for example depression and anxiety, from top to bottom, they cannot focus at the studies, and they get angry very easily, and they cannot sit still. They will have difficulty sleeping, and they persist, and they will have a persistently sad, guilty feeling, and they worry too much, and they worry persistently, and they cry incessantly, and they feel very tired. There may be some changes in appetite as well. Either they are going to gorge themselves in, or they're going to lose weight because of decrease in the appetite tendency. So they may go for arguments as well, arguments with the parents as well. So and any child with this such a depression, they will withdraw from the family, and they tend to get isolated, and they might spend a lot of time lying in the bed. Again, going for emotional disorder, anxiety. So anxiety is fear of something. And so fear of something is a normal phenomenon in a childhood age, and it varies. What they fear varies according to their age group. Particularly around the 6 to 12 year of age group, fear of school performance is a common thing. And beyond 12 years, fear of friends' rejection. Are we living up to the standards of friends' peer? That's the important fear they have. So if this anxiety is very persistent, if this anxiety regarding the school performance or any performance in exams, it's very persistent. If it is causing a day-to-day problem, and it is causing problem in the family, then we should address to professional psychiatrist help. There are other behavioral disorders which are also associated with suicide. So let me see each behavioral disorders in children which is associated with suicide. Truancy, that is school absenteeism and running away from school and running away from home is never normal. It should not be considered as normal, and a prompt psychiatrist help should be sought for. And stealing along with conduct problems in the school and with chronic lying is also a problem, should be addressed by a professional psychiatrist help. In case of attempted suicide, any child with an attempt of suicide should not be neglected, and the child will not recover by itself. It is a single most high risk behavior where the child again go for suicidal tendency. So professional psychiatrist help is an utmost important. There are other self-injurious behaviors can also be associated where we can seek the help. So there are children with substance abuse. Now it is becoming relatively common, and as a parent and family relatives, we have to pick up the child with substance abuse. How we can suspect a child is undergoing substance abuse? Any child with a neglected appearance, changes in the behavior, with irregular sleeping pattern, and repeatedly requesting for money, we can suspect substance abuse. So we have to seek professional help in this case also. How to recognize bullying, which is also associated with a suicidal tendency in a child. So any child who is having unexplained bruises, cuts or scratches, missing or damaged belongings, any child who doesn't want to go to school, it's a serious concern where the parent should ask for specifically for bullying, and if it cannot be corrected at home, again we have to seek a professional help. Cyberbullying now with mobile phone on everyone hands, cyberbullying become very common, and we should suspect cyberbullying when a child suddenly stop using the device, he doesn't want to talk about the online activities suddenly, and child is withdrawn suddenly. Okay, and this is a common phenomenon. We as a child specialist as well as other non-psychiatrists do encounter this problem. A child with mental illness can present with body pain, something like that, headache, neck and shoulder pain, back pain, stomach ache, and not feeling hungry, and the lump in the throat, or heavy chest, or tight muscles. So after doing all the imaging and evaluation, it came out to be normal. So doctors should know the somatoform disorders. That is, a child with mental disorder can present as body organic lesion. After ruling out all organic lesion, they should be promptly sent to a psychiatric help. So recognizing mental illness in a chronically ill child. Chronically ill child are again a special vulnerable group where the mental illness and suicidal tendency are relatively more common than the general population. For example, diabetes and epilepsy, what are all the signs I have mentioned before? Their parents have to look for all the signs of mental illness. So recognizing sexual abuse, again, the sexual abuse is also associated with suicidal tendency in a child, where they can present as behavioral problems or somatoform disorders, body pain, everything, and a child actively avoiding the abuser, which may be usually a relative. Child may show sexually inappropriate behavior for an age. Child may actually present with sexually transmittable diseases, or child can present with problem with the school performance. So who should be responsible to recognize all this mental illness in an adolescent behavior? Basically, everyone should take responsibility. The parent should recognize a child who is in need of mental health need help, and parents, family members, friends, and neighbors. There are specific programs like gatekeeper program. For example, Limans is providing such an help program to how to recognize mental health illness in an adolescent, and it is giving a training for social workers. And there are also mobile apps for non-psychiatric specialists provided by World Health Organization, such as Mental Health Gap Intervention Guide, which actually help other non-specialists to recognize the mental illness in an adolescent early. So what we are going to do if we are going to recognize it? So this phenomenon is a common occurrence. Once we recognize the mental illness and tell the parents or the family that the child should receive help from a professional psychiatrist help, they immediately deny it, and they doesn't want to hear the name of a psychiatrist or psychiatric help. They try to run away and they never go for a psychiatric consultation. So it's an opportunity missed to prevent serious suicidal attempts. So everyone should avoid the stigma. As we already know, mental health issues are very common in an adolescent age group, and any mental issues which cannot be managed at home, kindly seek professional psychiatrist help. And depression and suicidal attempts are treatable medical illness. So it's not a simple thing we cannot ignore, and we keep the child at home. So thank you. Kindness seems to be a solution to most of the problems, and I will be handing over the topic to psychiatrist Dr. Sainika, who will be briefing more on the issue. Thank you.
Thank you, Doctor. Thank you very much. We already have a few questions, but we will take questions after everyone has spoken.
Can I start sharing my screen, ma'am?
Yeah, please.
Sir, could you please stop your screen sharing, sir?
Yeah.
Yeah. I'll go ahead, ma'am. Okay. Is my screen visible to all?
Yes.
Okay. Very good morning, everyone. Thank you for joining on the Monday morning, and thank you, ma'am, for the introduction. So my topic is adolescent suicide, how and why. Very interesting to talk about suicide, and I take this platform as a media to talk about suicide, to bring more awareness among people regarding suicide, and to promote mental health and to break the mental health stigma. So without undue delay, let me go to the topic per se. So my framework is I'll be talking about brief statistics. Is the teen depressed? What are the signs of depression? Why depression and suicide? Stress diathesis model and conclusion. Sorry. I'm not able to move to the next slide. I don't know why. Yeah, sure. Okay. So coming to the introduction part. So suicide is a global mental health problem for people of all ages, accounting for nearly 8 lakh deaths every year. Like Dr. Nagarajan also mentioned the death of suicide. So India is the home to the largest number of adolescents, accounting for about one-fifth of our population is an adolescent population. And among the adolescents, what is the prevalence of mental health morbidity? Looking at the prevalence, it is 6% of the community samples and around 23% of the school samples report significant mental health issues. And in India, suicide is the primary cause for death among the adolescent population between 15 to 29 years. So also India has the highest suicide rate among adolescents, especially among females. The rate is around 15 to 1 lakh population. The rate is really alarming, and which is twice as when compared to the males, because males have only 7 per 1 lakh population. The suicide rate is quite high among females. When you look at across different age groups, different age group population, usually the death by suicide is more among males when compared to the females. Whereas among the adolescents, the death by suicide is more among the females when compared to the males. Usually males use violent methods of suicidal attempt like hanging or falling from the heights, whereas females use insecticide, pesticide consumption or tablet consumption. These are the most common modalities of suicide among females. So coming to the most important part, how to recognize signs of depression. Is my teen depressed? So the first foremost sign is feelings of sadness, irritability, anger, always sad, always irritable. The decreased or increased appetite, either eating less, too less, or eating more. Decreased or increased sleep, not sleeping in the night or excessively sleeping in the night and day. Always tired. I'm always tired. Feelings of fatigability, not interested in pleasurable activities. I used to play. I used to interact with my friends. I'm very social, but now I don't take any interest in doing all my past pleasurable activities. No interest in games, no interest in talking with friends, no interest in communicating with my family members, absolutely no interest at all. And expressing suicidal thoughts. I don't wish to live. Why am I living? I'm a huge burden to my family. I don't find meaning in my life, expressing all these suicidal thoughts. If the symptoms of depression, sadness, irritability is persistent over a period of 2 weeks, and these symptoms is going to cause impairment in child's functioning. The child is not able to perform at school. The child's performance and academic grades is coming down. Child is not able to perform at home. Then we need to think about the depressive episode. So symptoms of depressive mood with impairment in sleep and difficulties in falling asleep and changes in eating pattern, and these symptoms is going to affect the child's functioning, then definitely it is a depressive episode. So when a child is talking about suicidal thoughts, many a times parents bring to us saying that, no, it's just a threat. Is always trying to make such threats. Please, parents, don't feel suicidal thoughts, expression of suicidal thoughts as a threat. It is not a threat. It is a cry for help. The child is asking for help from the adults because of the depressed mood state. So these are the portraits of one of the depressed teen whom I could encounter in my clinic recently. So you can see the expressions of different emotional expressions of this child. So you can see the expressions of anger, the child crying, closing her face with shame. The portraits also say, end me. It hurts to watching it bleed. Emotions on and off. Sorry, I'm a loser. Little bit confused. So many. See, the child, the 16-year-old teen is expressing depression with a lot of emotional expressions of depressions in her portraits of drawings. This is how depressed teen come to us, to our clinic, to meet us with a lot of depressive cognition, depressive thoughts, helpless, hopeless thoughts, not worthy of living, self-harm thoughts, wanting to hurt himself or her, himself or herself. So these are the emotional expressions of a depressed teen. So why depression? Why suicide? So all of us think that, okay, you fail in exams. That is why a child has attempted suicide. Is that only reason? Is that only the failure in an exam has caused the teen to attempt suicide? Is it so? No, it's a myth for us to think there is a single reason for suicide. Always there are multiple risk factors. We need to remember that there is no single risk factor. Understanding suicide is very complex. It's not an easy, because it's a complex phenomenon influenced by the impact of biological, psychological, social, and environmental factors. Let me try to explain this in very simple terms. So we usually explain suicide to families in a stress diathesis model. So what is the stress diathesis model? So there is something called diathesis. Diathesis, which means your genetic makeup. When a child has the genetic makeup of impulsive aggression, which means the child is doing something very quickly without thinking, without a forethought, doing impulsively something without a forethought. This impulsive aggression is a genetic trait of the child. So the child is having this diathesis. When such a child who is already having the genetic makeup of doing quickly, impulsively things without thinking, then when that child is having some stress in life, it could be some life event, which I'm going to say what are the stressful life events for a child, is having some psychiatric disturbance, then the child has increased vulnerability for suicide. So a child is having genetic makeup for impulsive aggression. This child is encountering some stress in life, then the vulnerability for suicide will increase. So let me talk about the life events and psychiatric illness in my subsequent slides. So what is this diathesis? I spoke about the genetic makeup. So which means I mean to say that your genetic makeup of impulsive aggression is causing suicide. So what is the intermediate pathway? How does this happen? How does this exactly the genetic makeup translate to impulsive aggression to cause suicide? Which means there's something wrong with your brain. It's your brain. It's blame the brain, not blame the genes and not the child. So suicidal mind is the suicidal brain and suicidal brain is the suicidal mind. It's the brain, the neurotransmitter changes in the brain, the chemical changes. Chemicals are the neurotransmitters in the brain. there are serotonergic dysfunction, which means serotonin is a neurotransmitter in the brain. The serotonin level gets lowered in depression, gets further lowered in children with suicide. So in persons with genetic makeup, they become more vulnerable because their chemicals in the brain is lowered. Their serotonin in the brain is lowered. That is why they are suicidal. So these children who already have this genetic makeup of low serotonin, when they encounter life events or psychiatric disturbance, then the risk for suicide is more. So how exactly significant is this genetic makeup? How exactly significant is this diathesis? So to add importance to it, for us to understand about suicide, we all need to understand this genetic makeup. We say heart attacks or diabetes, hypertension, all these runs in families. Similarly, psychiatric conditions, suicidal behaviors all run in families. It's very important for us to understand there's a strong genetic basis behind it. And they say the heritability of suicidal behavior is nearly 30 to 50%, which is almost half is genetic because of the genes. It could be either direct genetic transmission or transmission of abuse. The mother who has experienced abuse in the early childhood is tend to abuse his or her child. And also modeling, the child can model mother's behavior of suicidal behavior. So it could be because of the direct genetic makeup or by modeling or by abuse. The suicidal behaviors are transmitted across generations. We also say this is a transgenerational transmission of suicide. Suicide is transmitted across families. So now I spoke about the diathesis. So diathesis, which means the genetic makeup of suicide, which is impulsive aggression. So when I have this genetic makeup, I encounter stress in life or I encounter some psychiatric disturbance, I become more vulnerable. So what is the psychiatric disturbance we are talking about? The child, if at all the child develops a depressive episode, the child started using the substance, or the child has contact symptoms, which means expression of severe aggression towards property, towards people, lying, stealing, the contact problems. All these are the contact problems. If the child manifests these contact issues, then the risk becomes more. Almost the presence of depression or a substance use increases the risk for suicide by more than 10 times. It is 10 times the risk goes higher. And also, when we look at the data, more than 90% of the children or adults who died by suicide had mental illness at the time of the death. So that significance is the development of psychiatric illness in those vulnerable individuals. So coming to the risk factors. So what are the risk factors? We spoke about the life events in the child. What can upset a child? So the child is having this genetic makeup, something is going to upset the child. Something is a risk factor for suicide. What is the distal risk factor? Talking about abuse, any form of abuse or neglect, physical abuse, sexual abuse, emotional neglect. So, or apart from this, a parental death of a parent by suicide, then the risk becomes more. The child will become further more vulnerable for suicide. Development of psychiatric illness in parents themselves, which leads into causing parent-child conflict, excessive parental pressures, poor parenting styles. And these are the risk factors from the family. And parents' expectation is too high. And lack of warmth in parents, poor parenting styles, authoritarian parenting styles, all these add as a risk factor. In the child who has a lot of relationship problems, maybe a romantic breakup or poor peer relationship, fear of failure, high self-expectation, stigma of failure, all these adds to the risk factor from a child side. So from the school, what are the risk factors in school? The bullying, the cyberbullying, as Dr. Nagarajan mentioned, academic pressure, huge academic pressures, high expectations from the teachers or the school, and poor support from the school. And also when the child has high media use, all these adds as a risk factor. So the child is vulnerable because of the genes and also the risk factors, like risk factors pertaining to the family, pertaining the child himself and the school. When added on all these, the risk for suicide becomes more. So coming to the conclusion, to conclude, suicide is a very complex phenomenon. It is influenced by multiple factors. There is no single reason behind suicide. Early identification and treatment of psychiatric illness in children and adolescents acts as a key factor in preventing suicide and promoting mental health among vulnerable individuals. Children and adolescents with signs of depression should seek help from mental health professional at the very earliest. And it's all of, as Dr. Nagarajan mentioned, it's the responsibility of the whole community, including having a supportive family, a school which is supportive, and a society where there is no stigma and people will start seeking mental health. That all acts as a protective factor for the mental well-being of a child. Thank you for this opportunity. Thank you.
Thank you, ma'am. Thank you very much. I mean, some of the new things that I learned today, that a child could be depressed, but then we don't even know that it could be the lack of support from the family that it's causing depression in the child.
Yeah, ma'am. Yeah.
I request Dr. Ravikant to please read his presentation.
Sure. Are my slides visible?
Yes. Ah, yes, sir.
The topic is treatment of adolescent depression. And first of all, I would thank Naruvi Hospital and for giving me this opportunity to be a part of this. So before we understand suicide, depression, everything, first understand what is self-harm, because these things should not be confused. Self-harm
I think Dr. Ravikant is not audible. Until he comes back, maybe we could take a few questions. Would that help? Dr. Ravikant?
Okay, I'm sorry. There is a network problem.
Yes, that's right, sir.
Very good. So, again, share this slide. So, is it visible now?
You are visible. At least we have a
No?
view. I mean, everything was gone suddenly. So you are visible.
Yeah. Thank you. So why do the teens self-harm? Self-harm is usually, it's a coping from their upsetting feelings. It is not suicide, because suicide is more about ending their pain. Here they need some relief from the pain, so they cope up with cutting, burning, carving, or hitting, punching, all this. And they serve the purpose of distracting from such feelings, feeling of sense of control, and feel something that they feel something at least, rather than feeling emotionally numb, and sometimes to punish themselves. Right. So we may get a doubt, why are they trying to seek attention? So for understanding this, we should understand that children are not good at talking about their feelings, and especially teenagers, because in general, the secrecy is a rule than exception. So they don't try to express their feelings as easy as a child. And so they may say some vague things like, I wish I'd never been born, or maybe I should just kill myself. And it may seem that they're actually seeking attention for some other tangible needs. It is possible they don't really mean it also. It's always better to understand this, and possibly they're seeking attention. Why they're seeking this kind of attention? What prompts them to do so? And remember that take all threats seriously and try to talk about it. So how, as a parent, what can you do? Sometimes it's so scary for the parent to see the child talking about these things and behaving certain ways. So first thing is, when you become upset, when you're visibly upset, when you're very sad, the kids then brush away these things and saying that they may say that I'm just kidding, I don't have such things, it's just about some upsetting thing. But it may be important for you to understand how to talk with the child. So if you are not sure how to go ahead, how to talk, so call a suicide helpline and try to talk and discuss with them how to go about it. You're not sure. And sit down with your child, take a deep breath and start asking questions. More than confrontation and questions, it's about talking. So you must explain why you're so concerned and what is the thing going in their head. And you ask the child directly, are they trying to kill themselves? Something like that. And also express your love. You always say that I'm there with you, I'm there, I love you, and I don't want anything to happen. And also try to understand what they're bothering them. You may talk with their friends or some other close acquaintances, and to understand. And while you understand, you always put yourself in the child's place, think in their shoes, respect their feelings, rather than outrightly saying that the child is just, or that the teenager is just showing the tantrums, or you don't need to feel it. Don't be judgmental. Comment on what you see, the behavior or the verbal behavior, non-verbal behavior, body language, and why you're so concerned. What is the change that you're seeing? And allow your child to talk more than usually what you do, and avoid any distractions. When you're talking with the child about these things, no phones, nothing. You don't allow any interruptions to happen. And don't ask too many questions. Ask a question and then wait. And it's okay if the child don't want to, the teenagers don't want to express, it's okay. The silence is also acceptable. Maybe after some time they may talk. Don't ask questions back to back. And always ask this question, that whether the child feels suicidal, even a passive wish to die. So ask the child, and don't feel that if you ask it, you're actually planting that idea. It doesn't happen. It in fact opens a conversation, because the moment you say this question, they may be tears in their eyes. That's when they open up. And always avoid unkind words. This is very common in our setup when we label the child, shame the child, and say that you get everything since childhood, you get everything, whatever you want. And now you're depressed. About what? I don't understand. What? And they also use a lot of counseling. The relatives will come, the family members will come, the teachers will come. Everybody to start counseling the child and tell them. And also very wrong patterns is when the parents themselves talk about their stories of depression, their own fight, their own problems that they face. It doesn't help the teenager at least, because now you should listen, not talk much. Listen. And then also don't diagnose that you have depression or you have some other problem. And also talking about the past events and not doing something, not doing exercise, not doing yoga, not eating properly. Stop giving the advices. Express the concern and offer the reassurance that I'm your side. It's a very bad time happening and we'll get through this together. We are there. I am there. What may ever happen, I'm there with you. So that's not the time to give advices. And help your child to see that there are different ways of resolving the feelings. Like some child has failed in an exam or didn't get a seat in NEET exam. So discuss other options. And all these options should be more of not teaching. It should be a kind of open discussion. You can think about other options and also develop an action plan. What the child agrees to, what the child don't agree. So if the child is shouting at you, yelling at you, asking to go away, that's fine. You don't have to respond immediately. Respond to everything that the child, even they may accuse you, blame you, the parent, for doing wrong. It's okay. So all these things have to be understood, and then plan of action should be made. And what are they committed to doing? And would they need a professional help? And when we can talk again about it? And also, don't make light of suicidal comments or use guilt trips. or dare the person to actually like threaten the child. If the child threatens, I'll jump from this floor. You cannot say, okay, jump. You cannot say that, because if you dare, even if the child don't want to, they will do, because that's the problem with the teenagers. And the communication of love and acceptance, these are the other things that the parent has to do. And also understand that we acknowledge the courage that it takes a lot of courage to talk about all this, to these hard feelings. And also express your willingness that we can talk again, maybe tomorrow or evening, and I'm there, I'm sitting next in the room, or removing all the dangerous items. Of course, the safety is important, removing all the dangerous things like knives, razors, and all the medicines. Don't keep the medicines anytime, because then you will repent. And also, the most important step towards overcoming depression is first asking for help. Offer the different alternatives that you have. What are the other options? You make your own research. You try to find out who is the best psychiatrist, psychologist. Don't first think about going to some kind of meditation, yoga, and all that. First talk. I think this is very important. First talk, and then all these things can be done later. And don't leave a suicidal person alone. And if needed, remove the latches if needed. And if the child already had attempted something like this, then okay, always crisis helplines, hospital emergencies, and then the mental health centers, child adolescent clinics, and of course other people who can help you at least immediately are the school counselor, psychologist, when you are not able to access a psychiatrist or a psychiatrist. The treatments we offer is individual and also family based. Individually, we can do psychotherapy or medications. Psychotherapy includes cognitive behavior therapy, where we try to change or alter the thoughts. Interpersonal therapy, where social skills, interpersonal skills are explained, how to form new relationships, how to maintain the older relationship, resolve the conflicts. And the DBT, directed behavior therapy, which is CBT with mindfulness. And other medicines I'm going to elaborate, and the supplementary interventions like doing exercise and improving the sleep. There are other things like motivation interviewing, how to motivate themselves to push themselves, like behavioral activation. What kind of medications help? There are two medicines which are FDA approved. There are other off-label drugs, mainly the fluoxetine. These are for the teenagers. Fluoxetine can be used even for younger children, up like from 8 years. And other factors, there are a lot of factors which will determine the previous medication which was already used, if it is used, and specific characteristics of the patient, comorbid illnesses, and also the choice of the caregiver. It may be medication, it can be psychotherapy, it can be combined treatment, and combined treatment always good. And the other medications effective? Yes, more than 50% patients with the initial treatment of antidepressants in teenage. And if they don't improve, we can switch to another medication or CBT and both. So what is the usual time? Usually it will take 4 to 6 weeks for medication. So we have to tell the parent right away, we tell the parent. And also how many days we have to use. Once there is 50% reduction in the depressive symptoms, from there onwards, 6 to 12 months is the usual duration. Common side effects are GI symptoms, headaches, agitation, sleep disturbances, irritability, activation. So we usually discuss with the parent. If the child is having less sleep, then we can give it in the morning. If the child is sleeping more, we can give it in the night. And gastrointestinal problems, these things we can handle with eating food properly and then taking the medicines. And there are some resources for the children to do. So I will stop the presentation here on, and I would like to listen more questions and answer them.
Thank you, sir. It was actually a very interesting presentation from you, although there were some glitches in the internet. But some of the things that you said, listen to the child. That is something I think we have to do a lot more. More often than not, we are not actually listening to the child, whereas we are talking down to the child. That's the biggest issue. And here there are a few questions already. And so the first question was, a lot of them have said parents tend to compare between children. So they have 2 or 3 children. These days it's just about a couple. Most of them have just 2 children. Or if they have just 1 child, they tend to compare it with the child next door. Recently, we had an incident here in Tamil Nadu where a mother actually poisoned another child because that child was doing better than her child. So it was a big shock to me. I never thought a parent would go to that extent. But these are like incidents that actually tell us something is very wrong somewhere. So as you people are, and we don't have child psychologists or counselors in most schools. So I would like you people to discuss this a little more and how we can suggest solutions. So, Dr. Shainika, Dr. Nagarajan,
Yeah,
all of you can respond to this.
yeah. The first incident which you mentioned where a mother has harmed the other child, like could be now we need to looking, there could be multiple factors. One important factor is we need to look whether the mother herself was ill, whether she had any psychiatric illness. There's a highest possibility, like in this case, mother could have had any psychiatric illness. It could be any form of psychiatric illness. It could be a depression or even a psychotic illness where because of some suspiciousness, she would have harmed or killed the other child. There's a high likely that mother could have had any psychiatric illness. So it is a little difficult. There are multiple factors in this. Like we need to go into depths of the case details and we need to find why the mother has harmed the other child. More likely the psychotic illness in the mother, that comes the highest possibility here.
Okay.
So the second question is, how do we prevent suicide? As Dr. Tangila mentioned, the most important thing is restricting the access to means of suicide. Most studies, both in children, adolescents, and adults, say that we need to restrict the means of access. Like that is why many of the Kodaikanal, High Point and Kodaikanals or Ooty, that is all blocked. The bridges are blocked because we are by restriction. The studies have found that the suicidal numbers have gone down. If we don't have with the access to all these high end points, the suicidal rates have gone up. So that is why all the access have been closed. So all the insecticide and pesticides, all that, there is a certain restrictions in holding in the shops because of this suicidal factor. So restricting the means of access is the highest first priority. The second thing is improving the awareness in children. A lot of life skill training is important in children. The children need to be aware, have life skill sessions in the schools. Our education system is hugely lacking in this part. We focus more on the education rather than it should be inclusive. We have to include the life skill education where we are going to teach children about the critical thinking, about the problem solving. How do we solve a problem? There may be multiple solutions to the problem, but suicide is not the only solution they need to seek for. There are multiple solutions. How do we seek for alternative solutions? How do they cope with crisis? How do they cope with stress? How do they cope with intense emotions? So a lot of things will come with life skills training. Already NIMANS is doing quite a number of life skill training workshop for children and adolescents at Bangalore. And psychiatrists and psychologists have also started doing life skill workshop for children across various places. So that life skill training will increase their pro-social skills. So when you increase those skills, when the skills in a child is better, so they will seek for alternative solutions rather than going in for suicide. So they'll be better at solving their problems. So they'll be better in coping with stress. So all this is the end point of life skill training. Also, the gatekeeper awareness gatekeeper program, which Dr. Nagarajan mentioned, like gatekeepers will, that is the teachers in the school will identify the at-risk children and children with signs of depression or suicide, and they will be referred to the concerned medical professional or a child psychologist or psychiatrist. And also there is interventions for at-risk individuals, at-risk children or adolescents. There are interventions for at-risk students. So these at-risk children in the school will be identified by the school counselors, and the school counselors will offer some counseling sessions for them. And even if the problems are persisting, then they'll be referred to the psychiatrist or a psychologist. So this is the pathway. So restricting the access to means of suicide with life skill interventions and better interventions for children at school level, promotion of mental health among the school, gatekeeper training program, all these are the suicide prevention strategies.
Ma'am, you've answered questions that were already here. Some people had asked about what are the.
Okay, glad.
I mean, like, I think these are being repeatedly asked, and so I would like Dr. Nagarajan, please tell me how do we improve in school settings getting counselors, given that schools are already struggling to have sufficient teachers and their salaries. These are issues that schools and managements are facing. So there must be a way where we can actually bring in counselors or make them also part of the system so that children have a healthy life.
Sir, you need to unmute.
Please unmute yourself, sir.
Yeah, it's a complex question, particularly in our political system, probably in all political system. Children and women doesn't have voice in the political system. They cannot ask for specific thing. There is not much of interest in the political system. Anyway, for the schools, right, there should be a mandate proposed by the government. Like counselors should be there. Now we are in a emerging phase. Right now, non-government officials are filling up the gaps, like 1098 and so many things they are filling up the gaps. They are providing some tremendous jobs, and I hope that in the near future that there will be a government mandate regarding mental health counselor will be there in every school, whether it is private or government institution. There should be some mandate like that.
Okay. Sir, please go back to your own presentation. Please tell us, how do we deal with the issue when there is a depression in the child? Now we understood very clearly what could cause the depression. It could be more often than not, the child spends about 8 hours of time in school and probably another 8 hours at home, then goes to sleep for another 6 or 7 hours. How much is the role that television or viewing television or the external society that plays in the child's mind, so that it is picking up all these signs from outside and it's actually responding to it? You get my question?
No, not clearly. You are expecting what's the media impact on the child?
Not media as in television channels, the entertainment part of the television channel, where children are being pushed into performing some shows, and they more often than not, I don't see that now frequently, but there was one particular program where the child was being the way the critical evaluation of the child's performance, it started crying. Every child in that scene, that particular program would cry at one particular some time or the other. That left a very bad feeling
Yeah.
to me as somebody who was watching the program.
Yeah, like in developing countries, for us, most of the parents are running behind marks. They see academic performance as the only solution and only successful story out of a child. It's not like that. There are so many business people and so many artists and so many who are actually better performing than most of the academicians. So right now, again, it's there should be changing over where academic pursuance is not the only goal for every parent. Not every parent should run behind the marks.
So here is one question. I can't concentrate on these. One child has, I don't know if it's a child. This person has said, I can't concentrate on studies because I am always in an imaginary world. And I like being in with my girlfriend most of the time. Is that, I think he's asking, is that right or wrong? He wants to know.
At least he is being frank here.
Yes.
I think probably psychiatrists should help here.
Is that a normal behavior? He's asking. There's no harm in having a friend and being able to talk to somebody other than you. But please.
May I?
Yes, sir, please.
So basically, before this, I want to tell one small thing. 5 years back, 2015, I met a girl who was in sixth standard or seventh standard. She was very upset because everybody in her class has boyfriends and she don't have. And so it's very upsetting. It just impacted her self-esteem so badly. I was in shock initially because I didn't know that. 6th, 7th standard. But now my son is in 6th standard. Now I understand this is very common. It is common. So we don't have to raise our eyebrows immediately when we see about this question. So now about the answer is yes. The child has to sit and understand what are his priorities. See, attraction, crush, everything. So that's the point that Shainika has told, Dr. Shainika, that life skills are very important. We are not here to judge the kids who is right and who is wrong. Yes, every feeling that they have should be validated. Validation is not saying that you are right. Validation is, I understand, you are getting these feelings, I totally understand. Now, but what is your priority? What do you want to, as your child, since childhood and even now, what is your goal? To marry? Or to study? Or to do something else? No. When you have the priorities fixed, you need a parent here. We don't need a great psychiatrist sitting there and talking this. We need a parent to be. And I strongly suggest all parents who are there out to read good parenting books. Like I would always suggest them to read one book written by Dr. Shekhar Sheshadri, who is a HOD, who was a HOD of NIMHANS. He wrote a book which is available in Amazon. That is called Parenting, Nurturing the Parenting. So it's just 200 rupees and 200 pages. I think parents should read those things. So they should understand what life. And every Sunday, instead of wasting the time on TV, one lesson in a life skill, half of the lesson also fine. If they can read with the child, do it for 1 hour activity. Because I don't believe that all schools are ready to do all these things. So now the parents should take steps. You just have to Google search life skills. You get it, you download, you read. First you read, then you sit with the child and do those activities. That's it. So I think these skills have to be imparted to the child by their parent. So the parent who does this question.
You're 100% right. I think it's more to do with how much time a parent spends with their ward. More often than not, when a parent says, I'm busy, I don't have time, the child picks up all the wrong signs. And I'm glad you brought this up because I think it's very important that the parents spend a lot of time with their children, and Sundays are devoted to children or whatever day. It does need not be Sunday, it could be some day that they are free. Just devote one particular thing. Like in yours, you said in your presentation, just devote, listen to the child. It is very difficult, I know, having children and ask, when the children ask questions and when you are in stress, it's very, very tough. I understand. So here is something, even brilliant CBSE students, now I think I have a problem with the question itself because please don't bring this idea of brilliance and it's all relative. But even brilliant CBSE students have problems when they are not able to get into a course of their choice. So here my question is, it's not just in school that we are talking, are we also including students who come into college? When they are in college and in first year or second year, we see that often in IITs, where very often students, suddenly they lose hope and they decide to take their life. And I know most of this college, at least in one of these heavier, where the workload is heavy for students, they do have a lot of other things happening to them. They have sessions with peer groups. Among them, they have a lot of discussions. How do you bring every child into the fold when something like most often than not, we don't really recognize depression, even among parents or among children. How do you bring them all into the fold? They may not be interested in the same thing. Every child may not be interested in the same thing. So is there a suggestion?
Can you come again with the question, ma'am?
I said, how do you bring all children into the fold in school or in college so that they don't get left out? They don't, when you're alone, often they say, see, for instance, when we covered suicides in institutions like IIT, they say we have a peer group, we have students, we expect them to come and talk to us.
So here comes again the importance of life skill training. So there's something called life skills training. It is an universal program which they implement in schools actually. So this life skills promotion training will help in building the critical thinking in a child or an adolescent or be it an adult. So how do we critically analyze a situation? How do we arrive at a solution? Problem solving, coping. So all this needs to be brought at a school or a college level to everyone. It should be a universal training programs for children and adolescents or an adult also. So at least for them to communicate, they should be good at communication skills. Communicate that, yes, I'm distressed, I'm unhappy, I'm sad. At least to communicate these difficult feelings with an adult or a close peer or a teacher. They should have good communication skills. So that will be imparted with a universal life skill program for all the schools. If we do the life skill training for children and adolescents or an adult, it will be a universal program so that children can start communicating about their difficult feelings and can start seeking help from adults or a medical professional.
So from
Also,
what?
like,
Yes, ma'am. Please.
Dr. Adolescent also can add on this point.
So here, maybe ma'am was asking little beyond the childhood, maybe the university students, right? College students.
Yes, yes.
Now here the problem
Older
is
adolescents.
we have to accept one thing. We cannot, every child cannot be in this fold. They definitely, you cannot force a child to have, make friends with others. You can always make them, like you can give them equal justice, but groups are inevitable. They have the kids, the teenagers will form their groups. So there will be some kids who will be left out. In such cases, if I'm talking about the parent, again I'm talking about the parent. Parent has to tell the child that one friend, earn one friend. That's it. You don't have to have a big group of people and then more bigger group of Facebook friends and social media. Have developed one friend, maintain the relationship, call them, talk with them, help each other. Then gradually think about the third friend and the fourth friend. You don't have to belong to a popular group always to be happy. All the popular friends will not be successful in their life or do great. There will be upsetting moments. So maybe I don't believe that all kids should be like together and no child should be left out. That will happen. Again, the parents' role is important. And school counselors, administrators, again, I don't have very great expectations, at least university level.
So here somebody, actually a teacher has asked, what is the role of a teacher in preventing suicidal tendency in a child? How can a teacher help, she's asked. I
So,
think she's a teacher, I have no idea, but I'm hoping that.
okay. First of all, thanks to the teacher for bringing up to this forum. I think teacher has to be given a great applause for this, asking a question on this. So first, the teacher should, if at all the teacher is identifying any change from the child's usual behavior. Child is usually so, but are there any unusual changes in the child's behavior? Like child is always with sad face, irritable or angry. The child's performance is coming down. And in that case, the teacher can talk with the child himself about the difficulties and can identify signs of depression from the child. So the child will state, yes, I'm sad, I'm depressed, I'm not eating well, I'm not sleeping well, I'm not able to concentrate, I'm having this helpless, hopeless thoughts. The child himself will start speaking about depressive thoughts. In that case, the identified child can be identified, and this can be discussed with the parents as well, and they can seek professional help in case of depression.
So
child needs to be reassured, and child to be at least at that point of time said that her feelings or his feelings is validated. Yes, we hear you, we listen to you, we understand that it is a difficult phase. This is what as a parent or a teacher needs to say at that time. Yes, we understand it's a difficult phase. We are here with you in this difficult phase. We'll help you. This is what the child needs to hear. We just need to listen to the child. Just listen to the child.
yeah, like we said right in the beginning, don't talk down to the child because it is smaller in stature than you are, but look at her or him as your equal. So that's, I think another teacher has asked the same question. What is a teacher's role in mental health of the child? So I think you'll have to repeat yourself, whatever you said.
No, ma'am. Here, I think one addition that I want to make what Dr. Teachers have actually limited role in handling these situations, especially because they have to report to the parents immediately first. Okay, so yes, and there lies the problem: how judiciously they use the words and how they cautiously talk to the parent. Telling the parent that your child has depression, I don't know what's the problem. Please go to a psychiatrist is an easy way. But better way is try to tell the parent, understand what the parent understands first. What do they know about the child, and then without ridiculing them, very cautiously use the words and tell them how important is the mental health. What could be the reasons, and we should say that it can happen with any child, and tell the success stories more than accusing the child of having suicidal thoughts, some huge problem in school age or hospital. So that's very carefully we should choose their words to the parent.
So I think we will have to end the session here because uh, we are running short on time. But then there are large number of questions and many questions. Given that the issue is so sensitive, it is nice that we are hearing so many people come up with a lot of queries, and most of these queries again boil down to the same thing. And your answers so far, all three doctors, all of you have been saying the same thing again and again. Speak to the child, spend time with the child, and make sure that the child is feeling comfortable when it is talking to you. And you are not talking down or ordering the child, instead, you are being a partner. So I think I have understood exactly what you're saying, and I hope the message goes out because a lot of these people have asked the same question again and again. If there are any personal questions too, yes, sir, please tell me, sir.
One last thing, ma'am. Because this was there in my mind, I forgot to tell.
Yeah.
Usually, we talk about when the child talks about suicide or changes in the behavior, then all this discussions happen. I'm talking about when the child was very young, as young as 6 years, 10 years. Start teaching the child about the mental health problems. How, when someone, some joke, some movie they're watching, they're showing the suicide, depression, and then all these things in a very lighter way, tone and all this, making fun of it. We should explain this is wrong, this is not right. And even if someone in the family attempts suicide, we should talk about the child, how, why these things can happen as early as 10 years, so that the child understands. You cannot suddenly explain mental health suddenly when they're actually starting behaving that certain. So they're teaching the child what is shown to you is not true. And so the stigma will come down. And this, the cost of stigma, what we're talking is, as Dr. Nagarajan said, 31 children are dying. That's the cost of stigma that we're paying today. So many, and in Vellore, there is a study done in 2004, like Aaron. They said 148 out of 1 lakh. It is 10 times higher than the national rates in Vellore, rural Vellore. That was a question asked to me in my DM exam. What was the highest suicide rate? That is in the Vellore. I think it's a high time that we should start teaching these things very basically from the childhood, not suddenly realizing it in the teenage and then later. That's it.
Dr. Nagarajan, do you have something to say before we wrap up?
Yeah, when we think of promoting physical health, right, we usually think of doing some exercise and eating some fresh vegetables and let's say, for example, putting vaccines. And there are similar options for promoting mental health as well. As Dr. Ravikant has pointed out, it should be started early. So life skills should be taught very early on. Parenting and family support should be taught early on. And any problem with the deviation which cannot be managed by the family, they should seek professional help without any stigma. That's the important point. They should not miss the child.
Thank you very much, sir. I think we will wrap up here because we are really running short on time. Thank you, Dr. Nagarajan. Thank you, Dr. Candela, and thank you, ma'am, Dr. Shainika. Thank you. It was a very wonderful session, and I learned a lot. And I also understand that a child should be treated as a human being and not be talked down to, not be instructed, but held on to as every child should be done. Thank you very much.
Thank you, ma'am. Thank you.
Thank you.